بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أعزائي الطلبة، أهلا وسهلا بكم. يتجدد اللقاء في الجزء الثاني من محاضرة Optical Coherence Tomography in Glaucoma. In this lecture, we will concentrate in some recent technologies that are used in the progression and early diagnosis and detection of glaucoma, like OCT angiography and visible light OCT, spectral OCT or retinal oximetry, and some of the adaptive optics. Now, we will concentrate in this lecture mainly in OCT angiography, as it is a recently emerging technology and it has wide applications in the field of ophthalmology and in other branches. But we will concentrate mainly in its application in glaucoma, as I said, in the early detection, diagnosis, and following the progression and establishing progression-guided analysis. We will start with the first slide. So the optical coherence tomography angiography is a new approach to visualize the blood flow, and it has a greater advantage to the patients and to the clinical practice. To the patients, reduced patient's burden to allow more frequent imaging. So we can do frequent imaging of the patient without any burden for him, unlike fluorescein angiography. And there is no side effect from fluorescein injection, so it can be used in pregnancy and so forth. Also, in the clinical practice, it has very fast acquisition and without any use of the dye, and gives you ultra high resolution image of the retinal vasculature in 3 dimensions with proper segmentation of the retinal vasculature, and it shows you the different slices and slabs of the OCT angio and the vasculature of each part of the retina. As you can see in the images below, the clear appearance of the superficial slab in the leftmost part, and then the intermediate or deeper layer. Then the dark area is the deep layer of the retina, which is avascular. That's why it appears dark. And the last one is the choroidal circulation, which has a special pattern. Now we will go one step further and deeper in the learning of the use of OCT in glaucoma. We finished speaking about the traditional structural OCTs. Now I would like to speak few words about the OCT angiography, which is an extension of the traditional OCT that uses the motion contrast to visualize blood vessels. And the evolution of OCT angio becomes feasible after the increase in the speed of acquisition of the image in OCT that make it possible to determine any moving particles within the retina, which is the red blood cells. So utilizing this option to give a motion contrast and give the impression of the flow. It is a non-invasive technique that utilizes useful in the follow-up and the assessment and the treatment efficacy. The principle based on the variation the OCT signals when there is a moving particles within the retina, that's the retinal blood cells. This will create a different signals from that moving particles, and based on special softwares, these signals undergo some variation and decorrelations, and accordingly a new signal will be created and gives you the flow image. This is the main principles of optical coherence tomography that is based on the motion contrast. So that various vascular parameters can be investigated. We investigate the vascular density in the optic nerve and peripapillary area, and also we study the flow index in the optic disc, and we can study the vascular density in the macula. In a brief, OCT angio, in contrast to the structural standard OCT, based on the principle of motion contrast detection, and hence it detects the flow signals. So it concentrates in moving particles or moving structures within the eye, that is the red blood cells. So OCT angio add or extend the spectrum of the traditional OCT to include the vasculature. However, the standard structural OCT based on the reflectance of the spectral waves to estimate the thickness, so it mainly concentrate on the static structures of the eye. So OCT angio is an extension and new innovations of the OCT, standard OCT. Now, as far as the principle based on the octa, that is the OCT angio, you can see a very nice vascular image that you can hardly believe that this image is without a dye. Now, in the traditional structural OCTs, the principle based on that, we have a light source, either broad beam light source or monochromatic light or swept source light source, that passes through an exploring arm and a reference arm. Now, the rays passing through the exploring arm, when they pass to the eye, they then get reflected back. Both the rays from the eye and from the reference mirror will pass through a detector that recognizes the difference between these two rays. And this is make the principle of image formation. This image formation is called the A scans. Now, different and multiple A scans will form the B scan, and multiple B scan pictures will form the three-dimensional image that is the basis of the structural OCT. Now, in OCT angio, we add the fourth dimension, that's the time. So the image in OCT is four-dimensional, including the three-dimensional image made by the structural OCT, as well as including the time, that we scan a certain point in the retina based on the high speed of the OCT. So this point is scanned many times, so that the two images are compared together. Usually these two images are exactly the same, except for any moving particle. That's the retinal blood RBCs, that's the RBCs. Now, the difference between the signal from these two images is called the decorrelation signal. The decorrelation signal make the principle of OCT angio and gives you the flow contrast, of the image. So this is the main principle of the OCT angio, that is it take multiple pictures for the same point. Usually these pictures will be exactly the same, except for any moving particles, that is the RPCs. And when we subtract the two images from each other, this gives you the motion contrast and gives you the flow. And this process is made by the OCT angio, is called decorrelation signal, as you can see in the image here in the right side. So you can see that the spot in the red here, this is an A scan passing through an artery, and another A scan passing between the artery and the vein. And in the lower image, the same A scan passing through the artery, but now it hit an RBCs, red blood cell. Now the signals from the two images are going together and then undergo subtraction and certain processing to gives you the decorrelation signal in the right side here. This decorrelation signal undergo further processing, so that gives you the final picture in the OCT angio. This is the principle of OCT angio, that we add a fourth dimension, that's the time in the measurement of the retina. The different modalities of OCT angio available in the market, they use different softwares to give you the final display of the OCT angio. The most common one is the SADA software, which stands for Split Spectrum Amplitude Decorrelation Algorithm. In this way, as you know, that OCT using different A scans and multiple A scans of the specific point in the retina will form the B scan, which is the two-dimensional image. And different B scans will give you the three-dimensional image. Now, this volumetric data of the three-dimensional image, by this software, it gets splitted, and this spectrum is gets splitted and displayed in 2 dimensions and 2 dimensions of B scans, so that each layer of the retina is split in slices of tissues, so that you can display them in 2 dimensions. So this is the idea of the split spectrum display, that the volumetric data given from the initial spectrum of the image is displayed into different small B scans and then decorrelated. By decorrelation, we mean that we subtract the static particles present in the image from the dynamic particles. When you take the initial image, it contains both the static structures and the dynamic structures. Now, by decorrelation, we remove the static structures, so only the moving structures will be displayed. That is the red blood cells. That's why it gives you detailed appearance of the vasculature of the retina as if it is being injected by a dye, but really there is no dye injection in a fluorescein angiography. This is the main principle of OCT angiography. As I mentioned earlier, that the principle behind the OCT angio to detect the moving particles or the vasculature of the retina based on special algorithm and softwares available that concentrate in particular points in the retina, and it takes a picture of the same point over a very short period of time. And this algorithm or the software do what's called decorrelation, detect the decorrelation signal. By decorrelation signal, we mean that we subtract the static structures from the moving structures. So the difference in this signal is called the decorrelation signals. Now, this decorrelation signals will give us the motion contrast. This is the main principle of the OCT angio. Now, this slide shows you the in-face image of OCT, the image made by the OCT named as in-face image. It's just a slice of part of the retina, slice on slice from superficial to the deeper parts, from the superficial retinal plexus, and then the deep retinal plexus on the left side, then the outer retinal zone, which is appear in dark because this part is usually avascular, and then up to the choroid plexus. So it gives you slices of pictures of the retina named as in-face image. Now this structures of the retina from the superficial part to the deep part, this is very important to show you the abnormality and the pathology in each layer based on the information that for example, in glaucoma, the most commonly affected area is the superficial capillary plexus, where it supplies the nerve fiber layer and the ganglion cell layer. And the deep layers of the retina is usually avascular. This slide shows the schematic representation of the architecture of the retinal blood vessels, which can be divided into a superficial vascular complex and intermediate retinal plexus and a deep capillary plexus. The superficial components mainly extend within the nerve fiber layer and the ganglion cell layer, and the intermediate capillary plexus extend from the inner nuclear layer to the outer plexiform layer, and the deep capillary plexus from the outer plexiform layer to the outer nuclear layer. And the outer retina is usually avascular because it is nearby to the choroid and receive its nutrition from the choroid. This is important to understand the different networks available in the retina and their impact in when there is any abnormalities, what's the changes that can happen, and also to understand that different types of diseases that affect different types of plexus. For example, in diabetes mellitus, you will mainly find the deep capillary plexus are involved and affected, and it did indicate progression of diabetic retinopathy. However, in glaucoma, you'll find that superficial vascular plexus is much more affected in glaucoma cases. In this slide, I will speak about the blood supply of the retina. As you know, the main blood supply of the retina is coming from the central retinal artery and from the long posterior ciliary arteries. And both the central retinal artery and the long posterior ciliary arteries are branches from the ophthalmic artery, which is also branch of the internal carotid artery. The central retinal artery and the long posterior ciliary arteries are end arteries, and by end arteries I mean that there is no collaterals or anastomosis with other arteries, and there is a tight junction between the endothelial cells that forms the basis of the inner retinal blood barrier. This is why this is important as compared to the choroidal circulation. When we speak about the choroidal circulation, you will find that the blood vessels are highly fenestrated and easy diffusion of substances from that area. And the tight junction between the endothelial cells, the tight junction between the retinal pigment epithelium form the basis of the outer retinal blood barrier. We have two blood barriers, inner retinal blood barrier made by the tight junction between the endothelial cells of the blood vessels, and the outer retinal blood barrier made by the tight junction between the retinal pigment epithelium. Now, the central retinal artery, when it passes through the optic disc, it will divide into an upper and lower divisions, and in contrary, each division will be divided into nasal and temporal branch. The same pattern will be followed in both hemiretinas, and usually there is no cross of blood vessels between the upper retina to the lower retina. Also, we will find that the central retinal artery form different plexus when it supplies the retina. The first plexus is the radial peripapillary capillary. Radial peripapillary capillary. That's mainly supplying the area of the optic disc. That's the innermost part that's of the optic disc and the adjacent areas. And from this same central retinal artery, we have two plexuses. The superficial capillary plexus that supplies the area of the ganglion cell layer and part of the nerve fiber layer, the retinal nerve fiber layer and the ganglion cell layers. And we have another two deep plexus, that's the intermediate and the deep capillary plexus that straddle the inner nuclear layer. So the inner nuclear layer lies in between of them. There is two plexuses, the deep capillary plexus and the intermediate capillary plexus. Both of them, they straddle the inner nuclear layer and supplying them. So we can say that the inner two-thirds of the retina is supplied by the central retinal artery. However, the outer one-third is mainly supplied from the choroidal circulations, and the outer retina, there is no blood vessels. This is why when you look in the OCT, you will find the outer retina is appearing dark because there is no blood vessels in that area. And the choroidal circulation is mainly supplied from the long posterior ciliary arteries, Another point that in about between 20 to 25 to 30% of the people, they have extra supply of the macula from the ciliary circulation, that's supplying the macula. And the capillaries of the network capillaries of the retina, they form the boundaries of the foveal avascular zone that's supplying every part of the retina except the foveal avascular zone, which is devoid of blood vessels, which is around between 400 to 500 microns. So this is in general, this is a general idea about the blood supply of the retina. Two-thirds, the inner two-thirds is supplied by the central retinal artery, and the outer one-third is supplied by the choroidal circulation. And the central retinal artery, along with the long posterior ciliary arteries, are branches of the from the ophthalmic artery. And the central retinal artery have different plexuses: the peripapillary capillary plexus, superficial capillary plexus, intermediate and deep capillary plexus, up to the outer plexiform layer. So we can say that the blood supply from the central retinal artery up to the outer plexiform layer. Beyond that, mainly it receives its nutrition from the choroidal circulation. As I mentioned earlier, that we have three capillary plexus: the superficial, intermediate, and deep capillary plexus. This is schematic representation of how the plexus appears and how the vertical connection between these two plexus or three plexus appears. And this is what you are going to see in the OCT. Now, the first one is the superficial capillary plexus. This is what you will see with the OCT angiography. You will see the large blood vessels and veins. They have straight course and branching and arborizing, forming a network around the foveal avascular zone. As you can see in this slide, they have straight course and then interconnecting blood vessels in between around the foveal avascular zone. The second plexus is the deep vascular plexus. Now, this plexus, you can see that it is formed by the vertical descending communicating arteries between this plexus, and this artery form a fan-like structure. As you can see here, small blood vessels vertically, and then a fan-like structure arborizing will be seen and converge all toward the foveal avascular zone. This is the density map. As you can see, it is exactly the same thing. You can see that these areas with the yellow color is the flow, where there is blood flow. The dark areas, there is no flow here. Okay, so this is the deep vascular vessel. The important thing about this deep vascular vessel, it is mainly made up of venous blood vessels. That's why it is commonly affected in venous occlusions and diseases affecting the veins. Now, the third layer is the intermediate capillary plexus, which is lies in between the superficial and deep capillary plexus, and this is commonly affected in case of diabetic retinopathy. These areas where you find leakage and you find hard exudates in these areas. So this is a quick overview of what you can see in OCT and what's the relation between the histology and what you see by fluorescein angiography. As you can see here in this map, shows you the flow in the superficial plexus, intermediate plexus, and deep capillary plexus. This slide also shows the different plexus. The superficial plexus, which cover the area from including the nerve fiber layer and the ganglion cell layer. And this is the appearance on the OCT, as how you can see this layer on OCT angiography. The intermediate capillary plexus from the ganglion cell layer up to the inner nuclear layer. And then the deep, and this is the appearance in the OCT angiography. And this is the deep capillary plexus from the inner plexiform layer up to the outer plexiform layer. And this is the outer retina. Now, the outer retina is devoid of any blood vessels. The outer retina receives the nutrition by diffusion from the underlying choroidal circulation, but there is no blood vessels in this area. That's why in OCT you will see it dark like this, because there is no blood vessels here. OCT angiography, I mean, appears like this. So this is the same explanation of the different plexus and the extension of each plexus, which area is covering. This slide shows the different terms that you should aware of it when you are speaking about OCT angiography. The first term, which is the segmentation. Now, the segmentation means the volumetric data that's taken by the OCT angio, which is a three-dimensional data block of tissues is measured. This is called the volumetric data or the segmentation. This is a segmentation or volumetric data taken by the OCT angio. Now, after taking this data, there is an in-phase projection producing a two-dimensional image, two-dimensional view of the segmented tissue with a three-dimensional vascular structure. This is the in-phase image. That is, you take a horizontal section like this, which is two dimensions, but the representation of the blood vessels in three dimensions. This is called in-phase image. Now, the slabs refers to a thick tissue section, such as the inner retina or the outer retina in two dimensions. Now, the same thing like this in-phase image, but in two dimensions, any part of the retina, this is called slabs. So volumetric data then gets converted to in-phase image, then the in-phase image is converted to slice or slabs. This is the different terms used in OCT angiography. Now we will go step by step to see the different maps of the OCT angio. This is the picture that you will see after taking the picture. There are different in-face images. This is the above four. This is the in-face images of the superficial layer and deep layers, intermediate layers, and also you'll find another maps that's named as VR. That's the vitreoretinal interface, and this is a structural image of the OCT, and this is a density map showing the density of the capillary plexus and the flow within the different layers of the retina. We will go one by one, see how to read each one of these images. So when you take the OCTA picture, the first picture will comes to you named as VRI. That's the vitreoretinal interface, which take the picture of the 300 microns above the internal limiting membrane. And as you can see, it appears dark because this area usually and normally there is no any flow or any blood vessels in this area. This picture is very helpful if there is any pre-retinal membrane or any pre-retinal hemorrhage or vascularization or new vessels in this area will be seen in this area. So this is the VRI, that's the vitreoretinal interface. Usually and normally it appears dark. The second picture you see is the retina depth encoded. The retina depth encoded. This is a pseudo-colored image of the retina. Shows the full thickness of the neurocysts retina are about 70 microns above the Broca's membrane, and the colors appears red, green, and blue. The red, this is the superficial retinal blood vessels, and the green is the deeper retinal blood vessels. Normally, you will not see the blue color, but if you see the blue color, this indicates the flow in avascular area. That's the deep layers of the retina. That's avascular. If there is any flow in the blood vessels at that area, you will see it blue. So this is called retina depth encoded layer. The third picture is the superficial layer, superficial vascular layer or superficial capillary layer of the retina. Which is extended from the internal limiting membrane up to the inner plexiform layer, and it shows the vessel network in the superficial layers of the retina. The fourth image will be the deep layer image, which shows the deep capillary plexus, which is extending from the from the inner plexiform layer up to the outer plexiform layer. And as we explained earlier, the pattern and the network that appears and the feeding blood vessels surrounded by multiple small blood vessels forming a network around the foveal avascular zone as explained earlier. And we say that this layer usually not seen in a fluorescein angiography. That's why this is one of the advantages of the OCTA that you can see clearly this layer. The fifth image, this is the ORCC image, that is the outer retina to choriocapillaris, that it extended practically from the outer plexiform layer up to 8 microns below the Broca's membrane. And this layer, normally there is no blood vessel, which appears here in the black color, appears in the blue color, as you can see here. That's just below the blue area. And there is no blood vessels in this area. What you are seeing here, the white dots, is the depigmentation from the retinal pigment epithelium. That's, you see the flow within the choriocapillaris. The next map is the choriocapillaris, which extend below the RB between 30 to 50 microns. And this is the area showing the choriocapillaris, as you can see in this picture. It shows a homogeneous appearance network like. The final layer is the choroid, which extend around between 64 microns up to 115 microns below the Broca's membrane. Okay, this is the area of the choroid. So in glaucoma, if we take a macular picture with OCT angiography, and we compare, the upper row shows the normative data or the normal appearance of the macula, and compare it with the glaucoma, you can see here in the superficial vascular complexes, there is arcuate pattern of decrease in the capillary density as compared to the normal, which is suggestive of glaucoma. However, in the ICP and DCP, that's intermediate and deep capillary plexus, there is not much changes between the normal and glaucomatous cases. So this can be clearly seen also in the thickness map in the GCC. You can see the difference in the thickness of the ganglion cell complex in the same patients. And if we take the picture around the optic nerve, we have the nerve fiber layer plexus, and the small capillaries around is called the peripapillary capillary plexus, or radial peripapillary capillary plexus. You can clearly here see the difference in the nerve fiber layer plexus and the superficial vascular plexus. So it takes the shape of which shape coincides with the glaucoma changes. And this test with high accuracy. The AROC value is 0.9. AROC value is a statistical measure to determine the accuracy of your test. It ranges between 0.5 to 1. So this is very highly accurate. AROC stands for area under receiver operating characteristics. So OCT angiography is very useful in glaucoma in terms of the macula or around the optic nerve. It is very important to remind you here that there is a lot of artifacts in OCT angio because of the high speed of the OCT and the high resolution. So there is a very too many artifacts in this modality. However, the most important is the projection artifacts. Now, we will have a separate lecture on the artifacts seen in OCT angio. But in this session, I will speak mainly on the projection artifact, which is the most common for OCT angio. That arise that do we still need the fluorescein angiography? Although the revolution of OCT angiography has made a lot of things easy, and the acquisition of high resolution image without injection of dye, and the visualization of the different layers of the retina make it a very useful technique to diagnose many diseases of the retina. However, there are some disadvantages of the OCT angio that cannot image the conventional latest stages of a fluorescein hyperfluorescence pattern, and like the leakage, the pooling, or the staining. This cannot be seen by OCT angio. However, this can be seen by fluorescein angiography. And also in fluorescein angiography, provide information on the dye, where the dye has gone either intravascularly or extravascularly, like this over time. And even with the fluorescein angiography, we can image even more peripheral. You know, in OCT angio, we concentrate mainly on the central part of the retina, because the resolution is inversely proportional to the area of acquisition. The more the area, the less the resolution. And if there is less resolution, it will not be useful technique. So the currently available OCT angio visualize the central area, the central 20 degree or 25 degrees of the retina. However, with the fluorescein angiography, we can visualize even the peripheral part of the retina if there is any peripheral neovascularization. So fluorescein angiography still has a role in the ophthalmology practice, and it has some advantages over OCT angio to some extent. Among the drawback or the disadvantages of the OCT angio, especially in the prototype modalities, is the presence of the projection artifacts. As you can see in the left image, the blood vessels are clearly seen, which is denoted in purple color, seen in the superficial retina, and there is a projections of the same blood vessels in the deeper layers of the retina up to the retinal pigment epithelium. This is called projection artifact. And when you look to the right side, where there is different frames of the capillaries in the superficial and intermediate layers of the retina, you see duplication of these images and make some sort of noise. All these are artifact and due to projection and shadowing of the blood vessels that is seen in the superficial and intermediate layers. And you can see here also in the deep layers of the retina, the deep plexus, which should be out of blood vessels. There is no blood vessels in the deep layers of the retina, but you can clearly see here there are plenty of blood vessels. All of these are artifacts. Now, by the application of this smart algorithm that is SADA, we can overcome the problem of the projection artifacts by fast image, what's called fast imaging, so that you can see clearly here that the projection in the left side has been markedly reduced, and in the frame, the in-face image or the vascular image that you can see in the superficial and deep layers of the retina, you can clearly see that the blood vessels are discrete and very clear and less of noise. And even you can see here the outer retina is black because there is no blood vessels in the outer retina. This is one of the big achievements of this software that make the projection artifacts very negligible. Now, after the problem of the projection artifact has been resolved, we can clearly see that the OCT, and by OCT angio we can determine 4 different types of plexus. That's the nerve fiber layer plexus and the ganglion cell layer plexus, and both of them they comprise or constitute the superficial vascular plexus. And this area is very important in glaucoma. This area is commonly affected in cases of glaucoma, and principles of early detection of glaucoma and the follow-up of glaucoma progression is based on determination of the density of the capillary plexus in this area. And the other plexus is the intermediate plexus and deep capillary plexus. Both of them, they constitute the deep vascular plexus. This slide is named as the density map. By density map, we compare the density of the capillary network and the peripapillary area of the optic disc, as well as the flow. This is important in cases of glaucoma. Now, on the left side here, this is a normal patient, shows the density of the peripapillary capillary plexus around the optic disc and the flow. And the next one, as you can see in glaucoma, where the damage usually commonly in the inferotemporal and superotemporal, you will find clearly the difference in the density of the capillaries between the normal eye and the other eye. And here it shows the percentage. For example, in this eye, 46.6% the capillary density. Inferiorly, here there is a reduction in the density, and also in the flow has been reduced in the inferior part. And this picture for advanced glaucoma, you can clearly see the difference in advanced glaucoma from the normal. So this map is very useful, especially in following patients with glaucoma. As you know, in advanced cases of glaucoma, when we reach to the floor effect of the structural OCT will be no more helpful in following the progression of glaucoma in advanced cases. In that stage, we need the visual field follow-up, as well as the OCT angio will be helpful in advanced glaucoma and following the patients with advanced glaucoma. Let's sum up some of the important facts after this preview of the structural OCT and OCT angio. So structural or traditional OCT parameters, that is the RNFL and GCC thickness measurements. This is the main parameters in the traditional OCT. However, OCT angio add another parameter, which is the density and the flow motions within the circulations of the retina, using successive images with a very high speed. Another important point, there is a moderate correlation between the peripapillary OCT parameters and the structural OCT. What I mean by this, that there is no strong linear relationship between the changes that occurs in the OCT angio and the changes in the OCT. What I want, in other words, that OCT angio changes might precede structural OCT changes. Another thing, that the peripapillary and macular vessel density are very important in following in moderate to severe glaucoma. You will find changes in the capillary density in the peripapillary area as well as in the macular area. And in severe glaucoma, along with the visual field progression, you will find significant changes in the peripapillary deep layer microvasculature dropout. In this slide, there is an example how we incorporate the structural OCT information along with the angio, OCT angio informations. This is a patient with a very clear right and left eye optic disc cube along with the macular cube. You can see in the the right eye here, there is a decrease in the thickness map, and clearly seen in the deviation map, which is marked in the red color here. Even when you look to the neuroretinal rim, there you'll find borderline thickness decrease, especially in the inferior temporal area, which is touching the yellow area here. So it means this is within the 5% probability. When you look to the angio map, clear decrease in the capillary density in the peripapillary capillary area along the inferior pole, which is suggestive of glaucoma. When you look to the other eye, the same thing. You can see this is the macular cube. You can see a clear redness in this area, which indicates significant reduction along the inferior temporal arcades of the other eye, and which is very clearly here in the angio map. So this is definitely a patient with bilateral glaucoma. This is another example of a patient showing both the macular cube as well as the optic disc cube, and along with OCTA. So this is structural along with OCT angio. You can clearly see here in this area, this is the thickness map, that there is some decrease in the thickness here in the superior and inferior part of the eye, which is clear in the deviation map marked in the red here. And similarly here in this area around the optic disc, you can see some yellowish area in this area. Now this is for the right eye. Now when you look to the angio map, very clearly you can see that there is the decrease in the density of the capillaries here in the inferior part as well as in the superior part. And even when you look to the neuroretinal rim thickness here, the TISNET map, you will find that there is a thinning in the inferior pole here of the optic disc. When you look to the other eye, a little bit is better than the other eye, but similarly it has some thinning here in the inferior part of the optic disc. And clearly you can see the angio map, significant reduction in the density of the capillary and decrease in the density of the flow in this area. So this is a patient with bilateral glaucoma. In this slide, just I want to emphasize on the importance of OCT angio in the following a patient with glaucoma, especially in moderate to severe cases in which the structural OCT became no more helpful in the follow-up. So we can do a trend analysis and event analysis using OCT angio, using different serial maps. In the event analysis, we follow point by point, and in the trend analysis, we follow the patient over a period of time that we can see if there is any significant progression, and even we can expect the future of these patients. So even the same principle that we use in the trend analysis and event analysis in the visual field testing as well as in the structural OCT, we can use the same principle in OCT angio. So it is a very helpful tool in following up the patients. Now, an important subject for every doctor who is interested in glaucoma subject is the glaucoma progression. In the previous slide, we spoke about the glaucoma progression and using OCT angio. But now I want to speak generally about how to establish a glaucoma progression analysis program or guided progression analysis. It is for any clinician or any doctor who is interested or dealing with a glaucoma patient, he should not be just satisfied with the diagnosis of glaucoma. The important question that he should be concerned about that is your patient stable or he's in a progression? And when we say progression, it depends on the stage of the patient he came to you. Now, if we speak about assessment of a progression at the level of the loss of function of the patient, this means at the level of the perimetry, automated perimetry. This is regarded as a late sign. If we wait till the perimetric changes takes place, and then we need to do progression analysis using automated perimetry, this means that more than 60 to 70% of his visual function will be lost before you can detect or determine the progression. So that is useful in case the patient came to you in late stages. If moderate or advanced glaucoma, visual field will be useful or even better than OCT in establishing a progression analysis and establishing glaucoma progression in your patient. However, if your patient in early stages, either he's in early diagnosed as glaucoma or in the pre-perimetric stage, at that time, OCT, either structural OCT or OCT angio, will be more useful in establishing glaucoma progression analysis. So our aim should be to detect your patient in early stage, and you once you confirm that your patient in a progression stage, you should establish a good treatment program to arrest the progression. Now, your aim is to arrest the progression either medically or surgically, Now, with the advances in the technology, as I said, in the presence of OCT angio, now we can detect progression much more early in patients, even in the normal stage. What we say progression in green. That is, when you do structural OCT, all the parameters of the patients is in the green zone. However, he still has abnormal loss of the nerve fiber thickness beyond his normative data. So at that time, we shouldn't wait. We should even treat him, even his parameters in the green zone. So this is called progression in green. In general, we have to establish a good progression analysis program for your patient. At least 3 visits are needed. One basic baseline visit is very important, after excluding the artifacts and the false positive and false negative results. And then you follow your patients to determine whether your patient is stable or not. Now we will come and see how to establish this progression analysis program. So to sum up, for advanced cases of glaucoma, because of the floor effect of the OCT, so visual field is better than OCT in establishing the progression analysis. However, in early stages, OCT will be better. And the floor effect, what's the meaning of a floor effect? I mean that beyond thickness of the nerve fiber layer of 50 to 60 microns, your OCT will no more show you a reduction of the nerve fiber layer thickness. Even if the nerve fiber layer thickness is in 0, your OCT will give you 50 microns. So this limits the use of OCT or structural OCT in the follow-up of patients with glaucoma in advanced stages. However, in early stages, it is very useful and very helpful. Now, as a general, and as we have seen in the lecture of perimetry, that we have 2 main important tools for glaucoma progression, which is called the guided progression analysis. The guided progression analysis divided into 2 important parts. That's the event analysis and the trend analysis. This guided progression analysis comes from the fact that a single OCT reading is not enough to determine the status of your patient. As a general, it gives you impression about the diagnosis and everything, but you cannot say is your patient is stable or not. And the single OCT report gives you information and compare it with the normative data, particular for that patients. However, for OCT progression determination of progression, we need a serial OCT reading, at least 3 readings, 2 basic readings and another readings over a period of time. And it depends on what type of analysis you are going to apply for this data. The event analysis means that you analyze a particular area or point in the visual field or in the OCT over a period of time and see it. However, the trend analysis, you assess the finding generally and globally over a period of time, and you can predict even the future of your patients. In comparison between the glaucoma progression using OCT and the glaucoma progression using the automated perimetry, OCT progression analysis has advantages over perimetry progression analysis in the context that it is an objective method for structural changes, that you assess the structural changes objectively. You are not dependent on the patient, unlike the visual field, which is a functional assessment, and it depends on the patient whether he's trigger happy or he's depressed or if there is any other problem. So the results will not be that reliable as a structural assessment. And this structural assessment does not depend on the normative data because you compare the different readings of the same patients. You need not to compare it with the different normative data. And it has no relation with the age, race, and refractive errors like that because we already stabilize these parameters because it is used for the same patient. So the spectral domain OCT has higher reproducibility with low test to retest variability. I mean that if you repeat the same OCT over a very short period of time, you will hardly find any test to retest variability, unlike visual field. Sometimes you measure the visual field today and you measure it tomorrow, you find difference because it depends on the patient's mood, patient attention, patient any coexisting factors. So the test to retest variability is high in the automated perimetry. However, since OCT is an objective method of assessment, it is less variable and highly reproducible. So it is superior to functional assessment as it is a structural assessment. And another last point that it is very important that the OCT help in detection in the pre-perimetric stage, which is an early stage of glaucoma. So if we follow our patient with OCT even before the changes appears in the visual field, that will be very useful in early detection and treatment even before the functional changes in the visual field appear. So, glaucoma is a large spectrum of a syndrome or a disease that start from glaucoma suspect. If you don't pick your patient at that stage, he will be converted to a pre-perimetric glaucoma. And at that stage, still there is no functional changes, only structural changes. And if you miss not to pick that patient in that stage, it will be converted to perimetric glaucoma. So proper management and proper assessment of the progression all are very important dimension in the management of glaucoma patients. This is example of the guided progression analysis for the iron film thickness around the optic nerve that we do in glaucoma patients. As I said that we have two types, trend analysis and event analysis. The event analysis analyze a particular local defect in the OCT or in the structural changes over a period of time and see if there is any significant changes. And there is a special statistical test applied to see if these changes are statistically significant and not, and is it beyond the test to the retest variability. However, in the trend analysis, we globally assess the structural changes in the OCT over a period of time. And maybe 3 or 4 tests are needed per year to follow these patients. And the aim of all of this is to determine whether your patient is stable with your medical treatment or he has any progression. And as I said, that this analysis is still under the pre-perimetric stage of glaucoma, pre-perimetric stage before the glaucoma appear. This is example of the guided progression analysis for the iron film thickness around the optic nerve that we do in glaucoma patients. As I said that we have two types, trend analysis and event analysis. The event analysis analyze a particular local defect in the OCT or in the structural changes over a period of time and see if there is any significant changes. And there is a special statistical test applied to see if these changes are statistically significant and not, and is it beyond the test to the retest variability. However, in the trend analysis, we globally assess the structural changes in the OCT over a period of time. And maybe 3 or 4 tests are needed per year to follow these patients. And the aim of all of this is to determine whether your patient is stable with your medical treatment or he has any progression. And as I said, that this analysis is still under the pre-perimetric stage of glaucoma, pre-perimetric stage before the glaucoma appear. An important advantage of the OCT, an important terminology is what's named as progression in green. It means that if you have your patient and with the use of structural OCT, even he has a very thick retinal nerve fiber layer, but over a serial period of time, when you check his OCT, you find there is a significant decrease in the thickness of the retinal nerve fiber layer. Even it is still falling in the normal zone, that is within the 95 percentile. So, for example, if the patient in the green zone and in the top 177 microns, and it falls down up to 89 microns, it is still within the green zone. But this drop in the thickness is significant, and this can carry a risk of glaucomatous progression. So this is called progression in green. This is very useful with the help or the advantage of the OCT, that we can determine the progression in green. So any statistical change in the thickness of the retinal nerve fiber layer more than 5 microns per year, this will be very significant, even if the thickness is still falling in the normative data. Now, this graph is very important to remind you. We have mentioned it before. It shows the relation between the changes in the retinal nerve fiber layer using the structural OCT and the changes on the optic nerve head that's seen by ophthalmoscopy or by any other method, and the visual field. You can clearly see and understand from here that the structural changes precede the changes in the optic nerve head, and they precede the changes in the visual field. You can see that the visual field is stable up to here. From here, this is the conversion point or the tipping point. It's called the tipping point and the conversion point, in which the visual field start to decline. However, the structural changes, they change very early, and even the optic nerve head changes. So this curve explains you clearly that by the use of OCT, we can pick up glaucoma in early pre-perimetric stages. So just because the metric is green doesn't mean that your patient is not gotten worsened, which is named as progression in green. So if your patient in a progression in the green zone, you might miss that he is at risk of developing glaucoma. Here I want to speak about the definition of tipping point concept. What's the tipping point? Now, if the changes in the structural OCT appears before the visual field changes, the question arises, when does exactly the conversion, the visual field will start? This is what's called the tipping point. It is found that decrease in the nerve fiber layer thickness around 75 microns, this is the conversion point. If you have, for example, the retinal nerve fiber thickness around 100 microns and it keeps on decreasing up to 75 microns, there will be no corresponding changes in the visual field. From the 75 microns onward, there will be decline in the visual field, and you will find the changes in the visual field. This is called the tipping point or the conversion point. Now, with the help of the OCT, we can determine this tipping point. Among the utilities of the OCT angio, and a new area of investigation is emerging, is the use of OCT angio to simulate visual field so that we can study the progression of glaucoma. Now, why we need to have a simulated visual field? Because the traditional automated perimetry that is available currently, they are, number one, they are not unreproducible, and you need at least 3 serial visual fields to confidently confirm and establish the diagnosis of glaucoma. And also for the confirmation of progression of glaucoma, you need at least 2 to 3 serial visual field studies. And you will see in the next slide that to achieve this, a marked reduction in the retinal sensitivity will be there before you confirm the progression of glaucoma. So as I mentioned earlier, that is at least 3 visual fields are needed to diagnose glaucoma. This is as mentioned by the ocular hypertension study. And by that time, a significant reduction in the retinal sensitivity, reaching up to 70% before you confirm the progression of glaucoma. And if you have 2 tests per year, you will achieve around 62% loss of the retinal sensitivity to determine the considerable and confirmed progression of glaucoma. That's why we need a simulated visual field that can simulate the normal visual field and is more reproducible so that we can detect and pick up progression earlier than this. Now, what's the problem of the structural OCT? By structural OCT, I mean the traditional available OCT that concentrate on the structure of the retina. That's the nerve fiber layer thickness and the GC complex thickness. So the problem with this structural OCT that it has a poor sensitivity for detection of glaucoma progression beyond early stage. It is very helpful and useful in early stages. In one study comparing the OCT along with visual field, they found that OCT is very good since it has good sensitivity in early stages of glaucoma. After that, it gets stuck with the floor effect, as I mentioned in earlier slides, the floor effect that the OCT cannot detect thickness or thinning of the nerve fiber layer beyond 50 microns. So even if there is more progression in the glaucoma, but still the machine will gives you the measurement that the thickness is 50 microns. So it has poor sensitivity in later stages of glaucoma. It's very useful in early stages of glaucoma. However, for visual field, it is poor sensitivity in early glaucoma because the changes in the visual field, that's the functional changes. The functional changes will appear late in the stages of glaucoma. And so it is useful in following the progression of glaucoma in later stages. OCT is useful in early stages. However, visual field is useful in later stages, as you can see in this study. Now I want to speak about the principle of simulated visual field. But before I speak about this principle, I want to speak about the Garway heat mapping for visual field and optic disc. Now, Garway establishes the anatomical relationship between the region of the visual field and the corresponding regions of the optic nerve head that be affected. So he superimposes the visual field tests pattern on the nerve fiber layer photograph. As you can see here, this is the picture of the optic nerve, and on the right side is the corresponding visual field defect affected. Of course, we are speaking about the central area of the visual field that is most commonly affected in glaucoma. As you can see here from the color present on the map, for example, the red color here inferiorly, which represent the inferior temporal fibers here, is reflected back here in the visual field, this color, the upper part of the visual field. Similarly, the blue one here, the superior temporal, is reflected inferiorly here, and the gray one here in the center is due to the papillomacular bundles, and the remaining part of the visual field here, the light gray area, this area, and the white is the far periphery of the visual field. So this principle exactly shows the topographic relation between the areas of the optic nerve affected and the corresponding areas of the visual field that to be affected. In the inferior map here, exactly it shows you the distribution of the nerve fiber layer. This is the according to the TISNET map. Now, this principle is very important because when we do simulation of the visual field, we will identify the areas of the visual field affected corresponding to the exact locations here in the retina or into the optic nerve. Here in this slide, you can see the how the simulated visual field appear, and as compared to the actual visual field, which shows the total deviation and the different areas and the sensitivity in decibels. And the simulated visual field based on the main deviation of the nerve fiber layer plexus, capillary density plexus. And the color code, you can see this is the color code that is used to shows if there is any deviation from the statistically the normal population, and if there is any statistically significant deviation from the norm. And the green color, as you know, usually represent this is within the normal distribution curve, that is within between 5 to 95% of the normal population. Now in this slide, we compare two patients with early perimetric glaucoma. We compare the simulated visual field with the actual visual field. You can see clearly that the simulated visual field is to large extent comparable to the actual visual field. Although the simulated visual field shows marked and severe disease as compared to the actual visual field. You can see the nerve fiber layer plexus mean deviation is -7 decibel. However, in the actual visual field is -4 decibel. But you can see clearly the areas affected are exactly and nearly comparable between the two visual fields. In this slide, we compare two visual fields, the simulated and the actual, in a moderate case. In a moderate case, you can see clearly that exactly the simulated visual field matches the actual visual field with a mean deviation of 8.2 decibels, and exactly the areas affected by the simulated visual field matching the areas of the actual visual field. In this last example or third example of advanced perimetric glaucoma, here the pattern exactly matches the simulated visual field pattern here, exactly matches the actual visual field. However, the simulated visual field shows better disease than the actual visual field. You can see the mean deviation is -11. However, the actual visual field is -17. Now, the way how we simulate the visual field using the OCT angiography, this is of course based on the Garway principle of the visual field. The area around the optic nerve is divided into 8 sectors, and these 8 sectors, they have exact mirror image, the upper half and the lower half, and the density of the capillaries at these areas, peripapillary area, determined the percentage of capillary loss, and this percentage is then converted to the equivalent decibel so that we can compare it with the visual field. This picture shows you how the different sectors around the optic nerve has been divided into 8 sectors and the corresponding area of the visual field that it represents. Again here, this is the same slide. We show how we determine the capillary density at the different 8 sectors. Then, after taking the mean deviation and the corresponding equivalent decibel value, so that we can convert it to a simulated the visual field and see the visual field of these patients. By the way, this software is still not FDA approved. This is just experimental, but it gives very good results as far as the comparison between the simulated visual field and the normal visual field of the patient. So in conclusion, we sum up that the simulated visual field using the nerve fiber layer plexus mean deviation is more reproducible than the actual visual field mean deviation. And this difference between the two is statistically significant, as you can see. And what we mean by reproducible, that is the test inter-test variability, that is test-to-test variability is minimum. That's if you do the test now for the patient and you repeat it after 2 to 3 days, the difference between the two visits will be a minimum. So it is more reproducible, unlike the standard visual field. So this makes the simulated visual field very useful in following up the progression of glaucoma. In this slide, there is a study for following a patient for different many years with the simulated visual field and the standard visual field and the OCT, and with the OCT angio, and you can clearly see the progression of the disease, and the simulated visual field very clearly show the progression of the disease. However, the standard visual field shows fluctuation, and the standard structural OCT stuck with the floor effect. So OCT angio may be very useful along with the simulated visual field in follow up the progression of glaucoma from early stages to late stages. I will speak a few words about the recent advance in the technology of OCT, what's known as visible light OCT, visible light OCT. Now, they found this is a new emerging modality that provides a new capability in both anatomical and functional imaging of the biological structure. Using this visible light source, it gives you a very high resolution with very high details. This is a new emerging technology, and it has very good potential for future OCTs. The visible light OCT, it uses a light spectrum that is in the visible range as compared to the traditional available OCTs in the market, which uses mainly four types of light source, that is the superluminant diodes and the ultra-fast laser, super continuum source, and the swept source light. You can see here the difference in the image between the four modalities. This is the visible light. You can see a histological structure of the retina, a very clear image that's seen by the visible light OCT as compared to the superluminance source or swept source OCT and the spectralis OCT. So you can clearly see the difference between the four different modalities. Now, with the help of this visible light OCT, we reach to a level that we can measure the oxygen saturation within the tissue of the retina, what's known as retinal oximetry, using a spectroscopic OCT. By spectroscopic OCT, we mean that we can measure the oxygen saturation based on the absorption of the visible light of the hemoglobin. The hemoglobin absorbs the visible light, and it gives different bands based on the oxygenation, the percentage of oxygen within that tissue. So using this spectroscopic OCT, we can have an idea about the oxygen saturation of the tissue, especially the ganglion cells, which is very important for us, and it gives you an idea about the metabolism of that tissue and this layer. And they found that it is related to the degree of damage that there in glaucoma patients. So the oxygen saturation reflects the degree of metabolism, which is in turn related to the degree of damage of the ganglion cells. This is another new modality using the visible light OCT named as retinal oximetry. So this is some of the important facts regarding this new technology. That's the retinal oximetry is a direct non-invasive imaging technique that allow for the assessment of the retinal blood vessel oxygen saturation. And as I said, that this reflects the degree of metabolism and in that tissues. So this might be a new useful tool for screening and early detection of the retinal pathologies based on the percentage of oxygen saturation of that tissue. Now, the third new advances in the OCT technology is what's named as adaptive optics. Now, adaptive optic OCT means that, as you know, that the OCT has an axial resolution and transverse resolution. The axial resolutions means the penetration, and the transverse resolution means the magnification in the field laterally. So the best OCT will have a very good axial resolution and a very good transverse resolution. But actually, this is in real practice is not available. As the resolution, the transverse resolution increase, the area to be scanned or seen by the OCT is decreased. So to solve this problem, they incorporate what's called adaptive optics, that is using a malleable mirrors and special mirrors that deals with the wavefront coming from the eye. When you throw a light to the eye, it will be reflected back based on the diffraction and the wavefront of that patient. Now, if we modify and we use special optics that correspond to that wavefront of that patient using the OCT, we will have a very good combination of axial resolution along with a transverse resolution. This is a new era of research and working is the use of adaptive optic OCT. So that the image will be at a cellular level. We will speak now on cellular resolution. Another new thing in the technology of OCT is the spectral shift technology. By spectral shift, that the machine itself can adjust the speed at different locations of the retina, so that according to your need, it will gives you a high quality image based on the speed of the OCT. As you know that the changes in the speed of the OCT gives you changes in the quality of the image, and it has an advantage and disadvantage. So if they could incorporate in the same OCT that it can changes the OCT speed based on your needs and based on the structure that you are scanning in the retina. This is called spectral shift technology. This is a new technology.
بهذا أعزائي الطلبة نكون قد وصلنا إلى نهاية هذه المحاضرة. نتمنى أن تكون قد استفدتم من هذه المحاضرة، والروابط موجودة الخاصة بالقناة على اليوتيوب أو على الفيس للتواصل. المحاضرة القادمة ستكون بخصوص Interpretation of Perimetry Map. نتمنى لكم التوفيق ونلتقي في المحاضرة القادمة بإذن الله، والسلام عليكم.